So I'm going to present another abstract now. This one was a completely different CAR, a different disease. It's remissions of multiple myeloma during a first-in-humans clinical trial of T cells expressing an anti-B cell maturation antigen, chimeric antigen receptor. We abbreviate B cell maturation antigen BCMA, and it's a somewhat confusing name. Although its name is B cell maturation antigen, it's actually mainly expressed on plasma cells. So B cell maturation antigen, a target for CAR T cell therapies of multiple myeloma. Multiple myeloma is an almost always incurable malignancy of plasma cells. Novel therapies are urgently needed. BCMA is also known as CD269. It's a member of the TNF superfamily. It is uniformly expressed on 60 to 70% of cases of multiple myeloma. We did extensive preclinical work on BCMA, and we were the first to ever publish an anti-BCMA CAR, and this work was published in Clinical Cancer Research in 2013. So if anyone's more interested in the background preclinical stuff, is there. By quantitative PCR, we found BCMA only in bone marrow, lymphoid organs, and organs known to have plasma cells in their lamina propria. By immunohistochemistry, BCMA is only expressed by plasma cells and a small fraction of B cells. This specific expression is very important because we don't want the BCMA to be expressed on any essential normal organs that might be harmed by the T cells that we infuse. But luckily, BCMA is strictly expressed by plasma cells and a few B cells. The CAR that we used in this study we call CAR-BCMA. It was synthesized and ligated into the MSGV gamma retroviral backbone. Replication incompetent gamma retroviruses were produced and used in T cell transductions. The T cells were produced in a culture process that took 9 days. T cells expressing this CAR recognize BCMA with great specificity. You can see the diagram of the CAR there. This CAR also had a CD28 costimulatory domain and a CD3 zeta activation domain. This is an overall summary of the patients we've treated so far. 12 total patients with a dose escalation study. You can see that the early dose was very low, 0.3 times 10 to the 6 per kilogram. We then increased the dose progressively, and when we reached higher doses of 3 times 10 to the 6 or 9 times 10 to the 6 per kilogram, we saw much better responses. Patient 10 had the best response on the study, but also significant toxicity. He had cytokine release syndrome, including fever, tachycardia, hypotension, elevated liver enzymes, and elevated creatinine kinase, all resolved in 2 weeks or less. The patient's absolute neutrophil count was less than 500 at the time of CAR T cell infusion and remained low for 40 days after infusion before recovering. It's now recovered completely. The patient was platelet transfusion dependent for 9 weeks after infusion. So this patient was really the patient who had the most toxicity on the study and also the one who had the best response. He did have significant toxicity, but is now recovered. Patient 10 also, as I mentioned, had by far the best response. He obtained a stringent complete remission, which is a very strict definition of complete remission used in multiple myeloma. His serum and urine immunofixation test became completely negative. His bone marrow flow cytometry for multiple myeloma became negative and continues negative now 4 months after treatment. Sorry, that was 3 months after treatment, 14 weeks to be exact. You can see his IgA curve up there, which is incredibly impressive with the very high IgA to begin with, and then at day 0, the CAR T cells were given, the IgA precipitously dropped down to undetectable levels at the current time. This is his bone marrow slide at multiple time points, and you can see the H&E staining showing the bone marrow cellularity before treatment, hypercellular, CD138 staining showing just greater than 90% of his bone marrow being taken over by bone marrow. The pink are the multiple myeloma cells, which are CD138 positive, and then BCMA, which was fairly dim in this patient's myeloma. In contrast, 4 weeks after treatment, his bone marrow was hypocellular, CD138 positive plasma cells were completely absent. I think that's the most important finding of the study, that we could completely eradicate the malignant plasma cells in these myeloma patients. In contrast to before treatment, the pink CD138 cells are completely absent. Again, 8 weeks after treatment, same findings. The bone marrow is recovering, cellularity is coming back, but the CD138 multiple myeloma plasma cells are still completely absent and continue to be absent at 14 weeks after treatment as of this week. This is the first example of a CAR T cell or any other type of T cell therapy completely eradicating or decreasing measurable multiple myeloma. So in summary, for the first time, we've shown that CAR T cells targeting BCMA can eliminate multiple myeloma in humans. We've demonstrated for the first time that CAR T cells can eradicate large burdens of multiple myeloma. Responses included an ongoing stringent complete remission in a patient with a high burden of chemotherapy-resistant myeloma. Of note, this patient was just seen this week. He's still in stringent complete remission. 3 months after an autologous stem cell transplant, he had 90% bone marrow plasma cells. So this treatment can work in at least one patient who had very chemo-refractory myeloma. I want to note these responses are obviously very, very early and require much more follow-up. Toxicity was also substantial but reversible, and similar to that seen on other CAR T cell trials. Amazingly, the toxicity was very similar to what we've seen in treating ALL patients, acute lymphoblastic lymphoma patients with CAR T cells in the past when we were doing CD19. The toxicity was very similar. Anti-BCMA CAR T cells are a very promising new therapy, but as I mentioned, very early and very, very early results that require much more follow-up. Thanks.